April 10th, I think Thursday, and this is House Healthcare. And this morning we have in with us, had you on our schedule for quite some time now. Glad that the day has arrived. It's Fertility Advocacy Day in the State House. So welcome, and we had you to tell us about your work. And I was telling somebody the other day oh no, this is when Alyssa's gonna cry, because I remember you were in here last year and I ended up bawling in tears. So I'm gonna need those tissues down here.
Yeah, we'll pass them down. I might need them too. We'll pass them back and forth.
Welcome.
Thank you so much. Well, good morning, Chair Black and members of the House Healthcare Committee. Thank you so much for having us and for giving us this opportunity to speak this morning. My name is Kate Weldon LeBlanc, and I have the honor of being the executive director of a nonprofit called All Paths Family Building. We are a New England-based nonprofit that provides emotional support, educational resources, and advocacy for anyone that is struggling with fertility and family building. And I am testifying today in strong support of House Bill 302, which is an act relating to health insurance and Medicaid coverage for fertility-related services. Our lead sponsor is Rep. Bartley. We're so grateful to her. Clearly, this issue and this bill has bipartisan support. It would provide private and public insurance in Vermont to provide coverage for fertility treatment, diagnostic care, and medically necessary fertility preservation. I'm so grateful for the opportunity to speak to you today. This is pro-family and joyful legislation. I'm proud to be joined this morning with medical providers, and there are others who wanted to be here, but they're with patients. And families, our dear advocacy partners, and most importantly, Vermonters who desperately need improved access to fertility care. We know that House Bill 302 is not advancing this year, but we are here because we want to respectfully ask that it be taken up next year. And I hope you will remember us and remember what you see in here today next year. So this bill will improve access to fertility care for Vermonters, hoping to achieve the family of their dreams. For those that want to be parents, it is one of the most fundamental human desires. For those of you that are parents already, I ask you to just think for a moment that isn't it the most important part of your life? Imagine if you were told you needed fertility treatment to try to have a child and you can't even afford to try, not even once. It is estimated that 1 in every 6 people globally will face fertility struggles. I have been the 1 in 6. My husband Joe and I struggled for years to become parents, which we wanted more than anything. I always say I wanted it more than getting married. He doesn't really like that, but being parents was really our deepest goal. We ultimately did IVF. We live in Massachusetts, so we had access to fertility insurance coverage. And we are extremely grateful to have our daughter, who's now 17 and who's here with me today. And going through that was one of the hardest things that we've ever gone through emotionally. Physically, it is challenging, of course, but to me, the emotional journey and the uncertainty of this, if this is ever going to happen, was by far the hardest point. But we didn't have the worry about finances because of having insurance coverage. So it's made my husband and I both very passionate about advocacy. And now I do it as my job as well. The lack of fertility insurance access in Vermont puts your beautiful state at a competitive disadvantage with your surrounding states in terms of attracting and retaining young residents who want to grow their family in the Green Mountain State. I know you all know this, but others listening may not. But Vermont has one of the oldest populations in the nation, with only Maine and New Hampshire as states with older populations. Unfortunately, Vermont is the last state in the whole Northeast to have a fertility insurance law. Every other New England state, as well as New York and New Jersey, have one. Without it, the majority of Vermonters do not have access to coverage for fertility health care. An exception to that is that state employees in Vermont do have fertility coverage. Some New England states have had fertility insurance laws for decades. Massachusetts was one of the first in the nation, but others have been quite recent. New Hampshire passed their law with broad bipartisan support in 2019, and it took effect in 2020. Maine passed their law in 2022, and it took effect in 2024. The advantage to Vermont passing a bill like this after others have done so is that we have the benefit of learning from those other states and being able to advance the best possible legislation. For example, we can now ensure that these bills are inclusive of LGBTQIA people right from the start, as we did in Maine, rather than other states like Massachusetts who are now trying to retroactively make them equitable. Another example is that some couples need IVF so that they can do genetic screening to prevent grave health conditions in their baby. People in this situation are left out of many states' definition of infertility, but they are reflected in the language of House Bill 302. We heard devastating testimony in Maine from a couple who knew they were carriers for a serious illness, but could not afford to pay out of pocket for IVF. So they tried to conceive on their own in the hopes that the odds were in their favor of not passing the condition to their offspring. But sadly, their baby was born with this life-threatening and life-limiting condition. And these families live with this challenge forever. And also health insurance is paying for that baby's and child's condition, hopefully for a long life. We have also learned to be specific in the language of the bill about what is and is not covered. There are limits built into this bill that align with other states and are not arbitrary. They are grounded in medical guidance. I also want to highlight an important aspect of House Bill 302, medically necessary fertility preservation. Fertility preservation enables patients to protect their future ability to have biological children after dealing with a diagnosis or treatment of something that may impair their fertility, such as cancer. We often hear that some young cancer patients are as concerned and upset about the potential loss of their fertility as they are about their own mortality. This might be surprising to hear, but again, think about your own feelings about parenthood. I know I care more about my daughter's life than my own. So I am happy to answer any questions you might have about this issue or about this bill, and I'm available anytime to all of you for more information. Vermont is such a leader in reproductive health care and so many other issues that we care dearly about. This legislation gives you a chance to be a leader again. Thank you.
Thank you. Can you tell us just a little bit about your organization, your work in within the organization, who you work with, and if people are okay with it, we could go around the room also and introduce people.
That would be wonderful. Yeah, that would be great. And Maggie's going to testify also. But yeah, that would be wonderful. So briefly, because I'd love for other people to talk. So All Paths is an independent nonprofit patient advocacy organization focused on, we advocate in all 6 New England states. And then our support and educational resources are available to anyone, anywhere, because most of them now are virtual. So we have support groups in all different areas of the journey to become parents. And we have a lot of educational resources like on our website and things like that. So that's a little bit about us. Is that enough? And then folks can share. We have a lot of different perspectives in the room. So you want to start?
I'm Jen McGarry with the Leukemia and Lymphoma Society, and we work on access and affordability issues. So anyone with a blood cancer, eye cancer, or chronic illness, we want to make sure they can afford the best treatment and into survivorship as well. And we are very, in support of this bill because everyone deserves to have a family. And we know the expense of that, and we're really very supportive of this issue. We're also working on medical debt, patient protections while we're here in the state as well.
Julie Frechette, I know many of you, I see you every day, but reach out to me after today if you have any more questions. But there's
My name's Kathy. I work as a fertility nurse at Northeastern Reproductive Medicine in Colchester and been working in fertility about 7 years. It's very near and dear to me for personal reasons and just because I so believe in it. And it's really hard to see patients struggle with the emotional and physical piece, as Kate said, and have the financial piece be something that's standing in their way. And that's an issue I can't solve alone. So happy to be here today.
I'm Teresa. I also work at Northeastern Reproductive Medicine. I'm operations manager, so I oversee patient-facing staff, billing aspects. So a lot of tough conversations with patients, heartfelt, tearful conversations on both sides, listening to the patient, trying to be strong for them, coming to these things, advocating for them, because it's really heartbreaking to just hear them want a baby so badly. That's really all they come to the clinic wanting, and they get met with all of these other things as far as financial stuff, the emotional, mental. So yeah, just here to support that. Love what we do every single day. Very rewarding work. So thank you for listening.
And my biggest surprise today, walking into the cafeteria, I'm like, Teresa. I used to work with Teresa
Oh.
before she left
Oh.
and went to Northeastern.
Yes.
Yeah.
Doctor, yeah.
Very happy. So.
My name is Sophie. I am Kate's daughter. I'm a senior in high school. And just like, I would say growing up with my mom being so open about, you know, how she had me, how she was able to have me, like, obviously I'm so grateful that she had that opportunity because I did. But I would just say, like, anyone who knows my mom, it's like, it makes so much sense that she is a mom. I think everyone should have the chance to experience parenthood in this way. And I think that it's just very important that that's accessible for us.
I'm Beth Senu. I'm a 10th generation Vermonter. I grew up just outside of Montpelier. Moved away to Boston for about 10 years and then married my husband and brought him back to Vermont to start our family. We could not conceive and went the IVF path. Actually at Northeastern Reproductive. And we're able to have our twins. This is one of them. He's and we were lucky enough to be able to pay for this out of pocket, and it's just really sad that some families can't have the family that we've been able to build because they can't afford it. So.
Hi, I'm Morgan. I'm actually a current patient at Northeastern. I'm currently going through IVF treatment. I am a Vermonter. I'm just bringing some awareness because I'm lucky enough to have some insurance through my employer, but we still have to take on quite a bit of financial burden, along with not only physically, but mentally going through IVF. My husband and I have been trying for a baby for about 4.5, 5 years. We've had a couple of losses in between, and it's definitely a very difficult journey. So taking, having some type of financial help to it, going through insurance would definitely help with it, because it is quite a big expense. And then having that, determining whether or not we can grow our family. Both my husband and I work full-time jobs. I work in healthcare, my husband works in construction, building Vermont. So we both really have always dreamed about growing our family and settling down in Vermont. And this is a big thing for us. We want to grow our family and bring them, grow them in Vermont, for sure.
I'm Val. I'm here to support my dear friend Maggie and women and families in general who are having to make some really difficult decisions financially. Shouldn't be this hard when you want to start a family.
I'm Claire Kelly. I'm the Chief Operating Officer at Northeastern Reproductive Medicine, and we're really grateful to be here today. We want every member of our community to have access to building their family in whatever way that means for them. And this is really important.
Hi, all. You know me, Jessica Breakfast, Planned Parenthood. We are a proud coalition partner and really support access and choice across all of reproductive health. So happy to be here.
Good morning. My name is Cindy O'Hara. I'm from the New North End of Burlington. I grew up next town over in Barry. I'm here supporting the legislation as a former IVF patient. I have the perspective of having insurance and coverage for secondary infertility. We were blessed with having a child unassisted the first time around, but I can definitely speak to the intricacies, challenges, stressors of even having insurance, how challenging it is. And so I'm very glad that some of the legislation language is very specific, which does and does, what it does and does not cover, which is always important. My husband and I also had to make very specific choices about our career to stay in the job that we were in, to continue to have the coverage that we had, which is very limiting sometimes. So I'm happy to answer any questions from the covered part. And I think that more coverage also brings more clinics, more doctors, more more new technology, which would broaden the availability and possibilities for a lot of Vermonters. I think every part of this is good, and I think everybody's on board.
My name is Meg York. I use she, her pronouns. I'm the director of LGBTQ Family Law and Policy for Family Equality, which is a national LGBTQ family organization. So we advocate for people to be able to form the families of their dreams. One thing that's very limiting for family building is access to coverage and access to care. Cost is a huge factor for people. And that's not to say that reproductive health care cost is inordinately expensive, because if you look at any other procedure, it's also expensive. The issue is really the lack of coverage. I'm a Vermonter. I live here in Montpelier, and when my wife and I were planning our family, now we have 3 children, all through assisted reproduction, we were asking people we knew for advice on what do we do about family building, and what they told us was move to Massachusetts. And that was heartbreaking. I don't want to encourage lovely families to leave our beautiful state. We should have that coverage here.
Hi all, you know me, Ashley Bartley. I was approached about introducing this bill and the fact that it's so inclusive. There's guardrails, it's really taken from other states who've already moved forward. As an individual who has suffered losses before and after my daughter, I couldn't think of any other legislation that I would more proudly support, and seeing everybody here tonight just means a lot. Sorry, I'm not usually a crier.
I told you.
I know.
It's your fault.
Yeah.
You were always happen.
Thank you for
Thank
And thank you, Rep. Cordes, for your support and leadership in the past. And we're so grateful.
Questions?
Yes, of course.
If, for anyone in the room that's willing to share, I'm curious about your experience with, insurance coverage of pre-implantation genetic testing. Has anyone had, obstacles? Has anyone been supported by their insurance companies around that?
I can speak to that. So I have a medical condition called PCOS. And then my husband, his mom had passed away from cancer. A lot of my family members had autoimmune diseases. So my husband and I decided we wanted to possibly genetically test to make sure that like our children couldn't, might not pass them on.
Yep.
However, I'm lucky enough that I have some insurance that covers fertility treatments, but the insurance does not cover to have our embryos tested for genetic disorder, like for anything genetic. So we were unable to test our embryos because it was such a financial burden for us, unfortunately. So now it's kind of like, have these embryos we have 11 embryos right now, but we won't know if they have any genetic variant because we just weren't financially able to pay for each one of those embryos to be tested, which is unfortunate. Yeah. Yeah.
And again, it's just not cost effective, obviously, to do that because there's a higher likelihood of loss, a higher likelihood of a complex healthcare issue in the baby, hopefully, that's going to result from those embryos. So this bill actually does not cover the genetic screening. Obviously, insurers, we hope, have the option to do it. It's not required by House Bill 302 as drafted. However, if patients had the other aspects of healthcare covered, they would have more ability to pay out of pocket for just that piece if the rest of treatment was covered.
Yes, with both my coverages, it was included in the possibilities. With the state coverage, it just accumulates to the $50,000 cap. So it is a very large chunk of the allotted funds that you do. The testing, when you have a genetically normal embryo, it is much more likely to implant upon transfer, which allows them to transfer safely one embryo rather than multiples. We did do some fresh transfer cycles where we had the IVF, and 3 days later we did a fresh transfer of the embryo, and those were not successful for unknown reasons. Whether or not they didn't implant, or they just weren't genetically normal. Unfortunately,
due to my advanced maternal age, this was necessary because we couldn't risk funds and expenses on things that would not possibly transfer and implant. And due to my advanced age, we had lower numbers of embryos created in each round. And so we had to freeze embryos and then test when we had enough embryos altogether. So we had to make those financial choices to freeze, then thaw, test when we had enough to make it worthwhile, because it's too cost prohibitive to test just one embryo. You want to test many. So we had to make a lot of these choices to fit within the insurance. We had the benefit of it being covered, which was wonderful, but it did eat a very large chunk of our coverage. These are choices that we had to make, like Kate said, because we could have chosen the other route and we would have just maybe transferred 3 embryos in at a time, took the risk that either some or all would implant, and they could have medical complexities, especially at my age. So these are the choices that we are risking. I understand the language as written doesn't require it, but like Kate said, if the funds were not being used for other pieces, that is a choice other people could make. And I believe there are medical complex people that don't want to pass on specific things, and that testing is completely separate and necessary.
Thank you for both of you for sharing.
Any other questions for Kate or, and then we'll go, oh, yeah, I haven't forgotten about you. So, Woody.
I'm curious, what is the cost involved, and how long does this process last?
So you mean the cost like out of pocket for an individual patient, or
Yeah,
what the?
For everything.
Yeah.
You know,
So I would say typically, like an IVF cycle and folks here know better than me, but I would say roughly speaking, just to give you a sense, it's typically around like 15 to 20,000. Just to give you a ballpark of paying out of pocket. That isn't necessarily what insurers would pay per cycle if when coverage was in place. And the timeline can be, you know, if you were asking about the timeline of like an individual cycle,
Yeah,
it can be definitely like a multi-month process for each cycle. And then usually you have to pause in between to if you have to try another cycle after that. So we are planning to spend this time between sessions, really looking at some of the actual cost data to other states that have passed these laws recently, particularly New Hampshire is so, unique to Vermont certainly, but has a lot of some similarities that would make it really, I think, interesting to look at their actual cost data. They have about, over 4 full years now of their coverage being in place. And so we want to look at what the cost impact might be on Vermont. But as others have been saying, we feel there's a cost to Vermont to not having this law. That's more difficult to calculate, but it is very relevant, and especially with the aging state and wanting more young families to come to Vermont, stay in Vermont.
and the Colchester facility, is that the only one in Vermont?
UVM has a fertility practice as well. And like I said, their team really wanted to be here, but they're delivering patient care, which I said, of course, we want you to do that. But but as far as I know, those are the only 2 places in Vermont. But to the economic development piece that Cindy mentioned, when a similar law passed in New Hampshire, in 2020, Boston IVF built out a whole full service IVF clinic in Bedford, New Hampshire. So it really what spurred the kind of traditional economic development piece in New Hampshire. Prior to that, they only had little satellite clinics and they sent everyone to Massachusetts. So we saw not just obviously for patients, which is our priority, but an economic benefit to the state. And that's why the Republican governor in New Hampshire signed it into law. He specifically mentioned the economic benefit of having a law like this and the risk of not having one.
Well, thank you very much.
Thank you for your
all of
questions.
for being here.
Thank you. So I'll move so Maggie can sit in the hot seat.
You're welcome.
Hello. So my name is Maggie Husband. It's nice to meet you all. I got in contact with Kate, I guess, about 2 years ago. I have been
going through, I guess you could call it infertility for about 3.5 years. And once I started looking into what it would take to go through fertility treatments and started paying, I haven't even gone through IVF, and I think I've spent about $10,000 out of pocket so far, despite having good insurance. I reached out to her because I wanted to become involved in this very important issue that is bringing healthcare to people in Vermont that deserve it. So I have a personal statement that I wrote actually
You have it.
about a year ago. But I wanted to read it because I think that it paints a picture of just one of the pieces of the horrible things that we all have to go through. It's going to be difficult.
Yes.
But it's important. So just give me I want to be taken seriously, so I don't want to cry.
I hope people take me seriously. It's already begun, so.
Okay.
Do you like a glass of water or something?
No, that's okay. Thank you. I'm a very sensitive and emotional person. In my whole life, people have told me you'll make such a good mother. And the fact that I have not had that opportunity is very, very painful. So it's always there. But when I speak about it in front of people that are willing to listen, it becomes harder to push it down. Okay. 89/70. I stare at this extremely low blood pressure, see my heart rate climb, and feel clots the size of baseballs pour out of my body. As an emergency department nurse with years of experience, I know this means I am dying. If I don't receive an emergency blood transfusion soon, I will not live to continue my fight to become a mother. As I start to black out, the physician who I work with enters the room, takes one look at me, and quickly shouts, "Blood now." After that, it is a blur of medical staff who I also work with in the ER, viewing my private parts and placing emergency lines and stuffing my body with medical equipment and trying to keep me alive to get to the operating room and working to save my life. What I have just described is one of an ever lengthening list of devastating events I have had to endure during my over 3-year-long battle to carry a baby. It was the first time I almost lost my life, but certainly not the first time my body experienced trauma trying to succeed with the most fundamental biological task, the one it was made to do. Countless doctor's appointments, surgeries and procedures, pregnancy tests, ultrasounds, blood tests, hours of research, anger, worry and sadness, lots of therapy, and perhaps most devastatingly, being forced to make choices on what testing and treatments to pursue and when. Due to financial reasons, I have not been able to pursue every treatment available to me in the medical field. The reason being that the state I live in does not mandate coverage for people with conditions like mine. And despite having what's considered good insurance, I pay thousands of dollars every year for out-of-pocket medical claims denied by my insurance company. My husband and I moved to Vermont from California for a better life. We were tired of heavy traffic, high cost of living, and the wildfires that came closer and closer to our home every year. As we both work in emergency medicine, my husband being a firefighter and myself being a nurse, it is incredibly insulting that the choices we've made to be contributing members of this community, serving the state of Vermont and its people, are met with the message that our desire to be parents does not matter and is not worthy of medical coverage. Unlike California and the rest of the Northeast, Vermont does not have a fertility insurance coverage law, which leaves many residents having to pay out of pocket for care. It is worth pointing out not only that Vermont pales in comparison to surrounding states when it comes to supporting its citizens, but also that it should not be up to corporations or the state to decide what is and isn't a medical condition warranting coverage. As a nurse, I frequently take care of patients who are objectively responsible for their medical conditions, and yet insurance covers 100% of their care. Despite how I may personally feel about these people's choices, I never let that affect my practice. I treat every patient with respect and quality care because I understand that they are deserving of it. My point is that morality and people's opinions on what should or shouldn't be deemed deserving of treatment or coverage has no place in medicine. I also did nothing to cause my medical condition and have tried desperately to do everything in my power to prevent further loss. The reason my husband and I pay hundreds of dollars a month into our insurance premiums is for the unexpected, for the hip replacement that might come with aging, for the allergy medications that might come with moving to a new climate that has 4 seasons, and also for the desire to have a child and the unexpected challenges that have accompanied that. And we should not have to choose between having an emergency savings fund in case a car breaks down or a roof caves in, flooding, even an emergency, even a vacation fund, much deserved after years of back-to-back miscarriages and a near-death experience, and paying hundreds of thousands of dollars to get the medical care necessary to increase our chances of having a healthy baby. Vermont has a swiftly increasing population of older people, many of whom are no longer in the workforce or contributing to the community in the way younger people can. In order to attract people who want to start families and are considering a move, or incentivize those who are already living here but need medical help to start their families, who will then in turn contribute to our community in the way that we want and need them to, it is in the best interests of everyone in the state to provide fertility coverage to those that live and work here. I am hopeful that Vermont will listen to its constituents and pass fertility insurance legislation. We deserve to have access to the medical care that we need. I will continue to fight until I and others like me are treated as human beings with dire medical needs requiring insurance coverage. Thank you.
Thank you. Thank you.
Does anyone have any questions for me?
Anyone have any questions? Oh, Laurie.
Comment as someone who also was in the ER with a miscarriage. I empathize with you and hope that I'm also a nurse. Hope that you felt supported in your care.
Yes, I did, and I was very lucky that because I work there, they took, well, maybe not because I work there, but I knew the people that were taking care of me and they took excellent care of me. It's just really shameful and embarrassing to be in that vulnerable position. I literally was in a hospital room spread eagle with my coworkers looking at me, which is, no one ever wants to do that. It's like the ER nurses joke, like, you never want to come in as a trauma because then they're going to cut your clothes off. Like, so much worse than that happened to me. And it actually wasn't even a miscarriage. It was surgery that I had that went wrong. I've never been to the ER because of a miscarriage because I don't want that to happen. But many women do come to the emergency department and they're having miscarriages, and we don't even send them to labor and delivery because it's not considered a real baby yet until they're 14 weeks, which is also really insulting. That's another issue. So yeah, it's been, it was really traumatic, obviously, to go through that. And then on top of all that stress, to go home and say, okay, how can I clobber together enough money to get through just one cycle, which may not even, I mean, there's probably only a 40% chance, if that'll even result in a pregnancy, let alone a baby. So it's just a huge, huge additional burden on all of us to have to consider that.
Thank you for sharing.
Well, Leslie and then Woody.
So this is obviously a difficult issue, and I'm wondering about your organizations and what kind of support, counseling, how does that get embedded in the care that you get?
Yeah, I mean, the emotional support piece, I would say, is the heart of our mission. I mean, I'm very dedicated to advocacy, but our organization started focused on the emotional support of going through this. And like I said, among many other things, the added financial burden we are concerned about because it adds to the emotional struggle, which is, even if you have coverage, it is one of the hardest things you can go through. And then when you have the financial worry, and when the financial worry affects your clinical choices, as you've heard today, it just really compounds everything. So we do our own support groups, and we also connect people to therapy. This is definitely one of the very, very challenging life experience, and loss and grief also, and medical complexity. All of it can be so traumatic. So that's the lens that we use. And I went through the Resolve website to find a support group for women with recurrent miscarriage. It's unfortunately a less common condition than infertility, which just not being able to get pregnant. So there isn't very much support for women that experience that. And I was able to find a support group through Resolve, which was the only place I've ever found that. So it's been helpful.
That's good to hear. Thank you. Yeah, good work.
And again, the bill reflects laws. Like I said, some infertility laws only focus on difficulty conceiving, and that is obviously a very important part of it. But we want to make sure loss is part of it, because some people don't necessarily have trouble conceiving; they have trouble, maintaining a healthy pregnancy, and so that's reflected in the language of the bill.
Yes. I hope it's okay to say this. We have a bill coming up. It's called S-27. It has to do with medical debt. And I never thought of fertility as being an issue with regards to medical debt. I'd always thought, well, maybe it's a heart condition or something really life-threatening. And I'm just curious, from some of my notes, I think it's 1 in 10 Vermonters face medical debt in their lives. And I was just curious, if you want, if you could raise your hand if you currently have medical debt.
There's someone behind you.
I will once I
Yeah, I'm in a cycle right now because I'm currently in a little bit of medical debt right now, trying to figure out how I'm going to proceed to pay for my next transfer after I just had a miscarriage less than a month ago, or about a month ago. And so we have to meet our deductible, but my husband and I now thought this pregnancy that we just had was going to be it. And then we ended up with baby, and now we have to come up with funds to be able to do our next transfer. So now we're kind of in a little limbo of trying to decide how we're going to be able to pay for that.
And also, I just asked another question. Do you know whether your hospitals or your facilities that you see, is there anything reporting from your hospitals about how to apply for assistance?
So my situation is unique in that, so like I said, my husband is a firefighter with Burlington, and I work for UVM. So my husband, his insurance, we pay a certain amount out of pocket every month for this insurance, and it actually has very low deductible, very low out of pocket cost. It's really great insurance. For me and any of our children to be on the insurance, it doesn't cost any more. So it's free for me to be on that insurance. If I were to go through UVM to get insurance,
I would have a monthly out-of-pocket expense, and then I would have a higher deductible and out-of-pocket maximum. UVM does offer very limited fertility coverage for its employees, which is a $15,000 lifetime benefit. And they cover it at a 50% payout. And so they would cover, after you meet your deductible, they would cover about 50% of one cycle. But for me personally, that would actually cost me money to have that insurance because I have the free insurance through my husband, which is better coverage. So UVM has a small benefit, but it doesn't even cover one cycle. And just for comparison's sake, if I were to move to New Hampshire and work for Dartmouth in their emergency department, I would make more money. I would have no income tax and I would have fertility coverage. So it's costing me money to stay in Vermont, but I like my job and I like living here and I want to contribute to this community. But I also want to have a family, and I wish that I didn't have to make these choices because it makes everything more difficult.
Leslie, I just want to expand on Woody's question, and I'm not sure if you're willing to answer, I totally understand. But has any of you had to go into a medical debt, into collections, and have to deal with that piece?
No, but for the fact that we use credit cards. And so we would use that for co-pays, for medications that were, again, they're covered, but there are co-pays. There are supplemental treatments that are not covered by insurance, like chiropractic and acupuncture, because they are not deemed necessary medical codes. And then all of these other things that just accumulate on top of insurance, they add up. And then once the insurance is gone, if you want to continue, then you're paying out completely out of pocket. And most clinics they don't have medical, you can't owe them money. You have to pay upfront or you won't have services.
I personally haven't gone through IVF yet because I don't want to get into the debt, but at this point I am considered advanced maternal age, which had I done it earlier, I probably wouldn't have needed to do the PGT testing because the younger you are, the less likely you are to have chromosomal abnormalities. So now that I am kind of running out of time, I'm going to just have to take out of my 401k or take out a loan or get into debt that could potentially go into collections if I were not to pay it. But I would have done it already if I could have afforded it, and I just haven't done it because of that reason.
Yeah, two questions. One was just prompted by your response about, did you say you use credit cards to avoid medical debt? Do you happen to know the approximate interest rate that you had to pay on the credit card? Because that's a form of debt that we're forcing people into.
Yeah, at the time when we made those decisions, the percentage rate, I can't speak to what they were, but the percentage rate was cheaper than the medical debt that was offered by the clinic.
Wow.
There's a financing option, a lot of times offered by different clinics, and the credit card was more feasible. And especially the long-term direct payment. Those are the choices that we make.
Yeah. It's like, which debt is better?
Right.
The second.
Debt costs less.
Yeah, exactly.
Yeah.
There's no debt, it's good. And then the second question goes back to something earlier. Because I didn't want to interrupt over Zoom. Well, I don't want to interrupt in general, but someone mentioned, because I was on Zoom, I didn't see you. You mentioned that in Vermont, state employees have coverage, but no one else does.
Yes.
Why is it only the state employees and not the teachers? Because don't they have the same insurance?
They do not have the same insurance.
Okay.
They have a separate, teachers do have a certain coverage
Yeah.
towards infertility, separate from the state. And there is a little bit, but it's not as.
So we have a system that creates like second and third class citizens, basically, like certain people get it and others don't, all depending on the kind of insurance you have.
I have the city of Burlington insurance and I have this much coverage, so.
Because of your husband being a firefighter.
And I mean, in New Hampshire, when the fertility insurance bill passed in New Hampshire, the teachers union there and public employees union there didn't have to follow the mandate, but they elected to do so because they knew they were competing with employers now that were mandated. And then I don't know, but I wonder if that maybe encouraged Vermont to add the same.
I specifically remember last year, one of our witnesses had left a very good career to go get a job with the state of Vermont at lower pay, lower, specifically for that coverage. So any other questions? Oh, actually, I have one question, and I'm not sure if anyone, it's approximately how many patients do you see in a year? Like individuals, at Northeastern?
Go through, like a cycle or come to the clinic, like Cassie might have.
Yeah,
We have about 650 new patients every year.
650.
New patients, yeah. So that doesn't include those who are currently in treatment or coming back for a second child or third.
Okay. All right, and is your facility roughly the same size as what UVM has, or is UVM a little larger or smaller,
In
or?
terms of volume.
Yeah,
Patient wise, yeah, I think they have more
Locations.
providers than we do.
okay,
But I also think there are certain things that they don't do at UVM that we offer at our clinic. I don't certainly want to speak to that, because I'm not 100% sure, but I know.
Our Colchester practice sees about 75%
okay,
those needing fertility treatments.
Okay.
And UVM does about 25. They're a little bit of a smaller program.
In my experience, UVM has a wait list as well. You cannot access treatment immediately. You go before where do they decide who can be slotted into the next one.
And that's a very important point because UVM has a 12-month wait list. And that's something we are very proud of and aware of, that we can get patients in right away. That is important. Time with fertility is crucial, and it is very important to get to see patients immediately.
I just want to speak on that because I was actually previously going to the exam clinic before I found Northeastern. And I was put on a 2.5-year waiting list. So before I could even try to do IVF, after having multiple miscarriages, going through fertility treatments, I was put on like 13 rounds of just medicated cycles, and then with little to no support. So just kind of getting the ring around. And then I came to Northeastern. I was able to connect with support groups, with people. And then I was actually listened to, and I was able to get started on something that I needed to do. We actually had to do IVF. I tried IUI, it just wasn't working. And then we had to do IVF. And so if I had waited the 2.5 years, I don't know where I would be, because it's still not, I wouldn't even be starting IVF yet to grow our family. So we still haven't given the call back yet. Yeah.
Actually, a board.
It's humiliating.
Yep. They decided that we weren't ready just yet. We still had to do all these other rounds, and it just wasn't working for us. Yeah.
oh, Brian?
Yeah, just wanted to clarify something that I thought I heard. You're paying out of pocket.
I have some coverage from insurance, but previously before I started my job, my job that I've been at for 3 years, I had to pay out of pocket for any fertility coverage, which put my husband and I in debt.
But so you paid completely out of pocket. Now
Yes.
you have some coverage, but you're
Yes.
still paying a lot out of pocket.
Yes.
And you were put on a waiting list.
At UVM, yes.
Yeah,
but
even
not-
paying money, you're
Mhm.
being put on, so even in a system where you can pay, you're being put on a waiting list, because we hear a lot about if we can't have universal health, there would be waiting lists.
Yep.
It sounds like it doesn't matter if you're rich, you would still be on a waiting list here? Like or do they take people if they pay more?
No, everyone gets on the waiting list.
Yeah.
So no matter how much you pay, you're on a waiting list, because there's just not access to the care.
I mean, honestly, that's pretty much every specialty at UVM. It's not even just fertility. So yeah, to your point with universal coverage, it doesn't, if you need a colonoscopy and you're not emergent, you're waiting a year. Like it's the same thing for every.
Thank you. I don't want to distract from this important topic, but maybe you'd come testify another time about waiting lists and other parts of the system of care. because I don't want to distract from the seriousness of this specific benefit we're talking about. But it's just sad that people have to wait because it's extra time sensitive. I hear that.
Yes, but as Kate said, the competition and emergence of more clinics will come immediately with coverage because
Yeah.
more people will have the availability and more services will be available. And there'll be more options.
Thank you all so much for coming.
Thank you so much.
Wonderful to have you.
Wishing you the best.
We can go off.